Hi, good afternoon, everyone. Welcome to the Montreal Heart. We have a very interesting case for you today. My name is Dr. Noser.
Hi, everyone. I'm Guillaume Marquis-Gravel. I'll be the second operator.
I'm Jamina. I'm the interventional fellow.
So we'll present to you our interesting case. Jamina, can you please go ahead and present?
Yeah, so this is an 84-year-old lady who has a background of hypertension, type 2 diabetic, on oral hypoglycemic drugs. She's got adverse BMI with a weight of 104 kilograms.
You can show the next slide, please.
And she has a history of atrial flutter on a DOAC. He was admitted with a non-STEMI and a troponin of 3,000 with a transthoracic echocardiogram showing good preserved left ventricular function. It was a difficult examination due to her BMI, but there was no obvious regional wall motion abnormalities.
So she was transferred to the CAD lab for an assessment of the coronaries. Can you show the next slide? Thank you. So the first shot was a shot of the right. So as you can see, there was a.
Can you show the angio, please? Can you go to the PACS images?
Thank you. Can you show the right first? Perfect. So there's a severe disease of the mid RCA. There's a long segment with moderate to severe calcification, about a 70–90% stenosis. This is the right dominant artery. Can you show the next one? Okay. Can you show the left? Perfect. So the left main and the circ are free of disease. We can see there was some calcification with only less than 30% stenosis of the marginal. Next, can you show this one? The mid to distal LAD looks fine, but there's some calcified, and we had doubt on the proximal LAD here. Can you show the next slide? Here, so you see it's like grayish. This is more a little bit hazy on the proximal LAD, so we had a doubt on this. Can you show the last one, please? Here. Okay, so we decided to assess physiologically the LAD.
And also there was slow flow down the LAD.
Right.
And with the calcium and our suspicion of prox LAD disease, we wanted to make sure if we're dealing with single vessel or multi-vessel disease.
Right, so we went forward. And you want to take over here, Mohamed?
Yeah, sure. So we decided to evaluate. For us, it was clear that the RCA was a significant disease, diffuse, calcified, that needed addressing with atherectomy and imaging. And the LAD, we wanted to be sure. So best way to evaluate that is to interrogate. We decided to perform an IFR, diastolic waveform measurements. Here we're working in a Philips room, so luckily we have access to the IFR pullback, which helps you determine if there's a step down, a step up, and at which point is the most significant disease. So can we show the IVUS pullback, the IFR, please?
Where is that?
Yeah, that's the one.
Fuck.
So we have access to the co-registration. We had a distal measurement of IFR of 0.88. And in this case, we're positive. And then we performed injection and a slow pullback. And as you can see, there's a delta that goes all the way approximately to 0.93, so over 20 millimeters. But if you look at it angiographically, it doesn't look significant. It's moderate disease, it's not severe. And I think we clearly have a culprit. So in this case, we discussed it together and we thought we can complement this exam with adenosine. And we'll discuss this later on, but we already have a pacemaker in place, so there's no worry of bradycardia. So we're ready to do the adenosine now.
Yeah, so we have the FFR wire down in the mid distal LAD. we're about to inject the adenosine. So here we go.
So we saw some T-wave changes indicating that it was efficient. And here you can see the measurement. So the lowest we got was 0.84.
Right. And it was effective because the pacemaker took over for a little bit. So the adenosine was quite effective. So the FFR is negative here with 0.84.
So I don't know if you agree,
so
but
I think we're pretty confident that it's fine to leave the LAD alone. We'll call that moderate disease.
And in this 84-year-old lady, if we can avoid putting extra stents, that would be, I think, ideal situation because we're anticoagulated anyway.
Yeah. So clearly the culprit is the RCA here.
We'll do one final image on the left system. Good.
Here we go.
Now, can we have the next slides? We'll continue to our discussions. Gauche.
All right. So so as you saw, the right RCA was kind of severely calcified. How we say that is because we could see the artery even before the artery was moving, and even before we injected contrast. So just by this is a definition of severe calcification. It's very diffuse as well. So we elected here to go with rotational atherectomy. We have access, we're very, very lucky here. We have access to rotational atherectomy, orbital, laser, and also IVL. In this case, we debated whether we would use rotational atherectomy or orbital atherectomy. So the pros and cons of each of the strategies, well, rotational atherectomy is the one we definitely have the most experience with. We've been using it for decades now. Rotational atherectomy is useful here because the artery is not that tortuous. Rotational atherectomy is only useful for suboptimal calcification. It doesn't break or it doesn't do anything to the more profound calcification. Here in this case, we don't know if the calcification is deep or superficial. So we decided we would use rotational atherectomy first and then study the lesion with IVUS to see the extent of lesion preparation and then decide on the next strategy if necessary or not.
That's a very good point, Guillaume.
Yeah.
Regarding the orbital versus the rotational, because as you know, the orbital, the crown surrounds the intima, and it has access to superficial and deep calcium. In this vessel, I estimate the size to be 3.0, 3.5 visually, but there's a proximal subtotal lesion also. And from my experience with proximal subtotal lesions, rotational atherectomy tends to have a better access to the vessel because of the higher speed, better penetration force. And I think if we use a 1.5 followed by a 1.75 burr, we might get access to some of that deep calcium if there is, but this we'll find out once we start.
And if it doesn't work, and if there's still some deep calcium we cannot get rid of with the rotational atherectomy, we can always use the rotatripsy strategy afterwards. If we see some deep calcium, then we have IVL and do some lithotripsy if necessary.
Definitely. So our setup at this point, as I explained, we have a pacemaker in place via the femoral artery, and we took a JR 3.5 7 French, and the 7 French enables us to use the 0.175 burr. Check. Center, please. So I like when I do rotational, any type of atherectomy, I prefer to go with either a workhorse or a CTO wire off the bat. I don't know about you, Guillaume, but for me, it's easier that way. And then I switch. So that way I don't need to worry about manipulating a long wire.
No, I agree with you. I mean, the floppy wire or the vapor wire for the orbital are quite difficult to get around with. So when the calcification looks just a little bit hard to cross, well, it's always a good intention to try with a workhorse wire we are used to. We put it on a microcatheter up front, and then that makes things way much easier afterwards. So here we use a turnpike as a microcatheter. Here we go. We're just going to cross the lesion with the turnpike, and then we're going to remove the workhorse.
So it depends how severe the lesion is. If it's not very, very severe, you can just deliver it like you're delivering a tube, like I did right now. If you're dealing with a subtotal lesion, CTO-like, at that point, then you need to torque the microcatheter to be able to deliver it more distally. Can you please test?
Yeah.
So I think this is a safe place to park the wire.
So here in this case, we use a turnpike, but we could have used easily other microcatheter that don't need to be torqued, just as a fine cross or the Caravelle and so on. But we never know up front, so you're gonna put the wire in the
so
PDA,
it was small
PDA
branches
here.
and some PVCs there, so I decided to go to a larger branch in the PDA. Can you test, please?
I think you're in the PDA here.
Yeah. So if you were dealing with a RotoWire or a Viper wire, probably would not be able to deliver here right off the bat.
Right.
You need to form some sort of exchange. Let's store this, please.
Okay, we're gonna take the floppy wire.
So now we'll take the floppy wire.
Yeah.
So as you all know, the floppy wire, it has a distal radial peak tip of 0.014, and the body of the wire is 0.009. And you can't use an alternative wire for this to perform rotational atherectomy. Versus the Viper wire for the orbital, which is 0.0010 on a distal tip, also is 0.014. It's an exchange length wire, so you need to be mind of that, and you need to manipulate it delicately, because if you have a kink on this wire, doing the rest of procedure is cumbersome, and you might need to swap wires.
So the idea here is that we want to prepare the lesion. We don't necessarily want to debulk much aggressively. So we are looking for a ratio that we think will be around 50 to 75% of the artery diameter with the burr. Thank you. So we're going to start up with a burr 1.5.
Yeah, because it's important to note, if you go higher in the ratio, your risks of having no reflow are much worse.
Yep. Or any type of other complications with the rota.
Definitely.
Which would not have been a consideration may we have used the orbital atherectomy, because it's a kind of one size fits all.
Yeah.
So
it tailors itself to the size of the artery.
Right. So 1.5 burr, and can address any types of size of lesions.
All right. So we're ready. We're using today here the RotaPro. RotaPro comes already mounted. You don't need to do any of the mounting unless if you want to change the burr. So it's very important to have your drip ready. Make sure that the burr slides smoothly, because sometimes there are defaults in the system. Everything is good. And when you fixate it, make sure you fixate it at least at 2 to 3 markers from the tip. And that way you get rid of any tension that accumulates in the system while you're going up.
Yep.
And today I'd like to demonstrate to you a very useful technique if you're doing rotablader on your own. It saves you hands. I call it the one-man technique. It's been demonstrated online a few times, and you can find it easily on YouTube, but I find it very useful. When I deliver my burr on the wire, I like to point it downwards so my drip falls on the wire, lubricates everything. And then you stop about 10 centimeters from your two-way, and that's when you test your speed. In this kind of case, I'd be using a regular speed, 170, 180 revolutions per second. Are you ready? Go up. Okay, let's test.
Ready?
So let's go. Go to 180. Okay, very good.
Works fine. Okay. So show us the one hand technique.
Yeah, so I'll ask for Guillaume to help me here open the two-way so I can insert the burr. So you have one hand at the back, and we'll put the wire in the sleeve. So then one hand pushes and the other hand pulls. So, okay, you can let it go now.
We do that
So under fluoro,
usually under fluoro to
if
make
you watch
sure.
my hands, I have one hand pushing, the other hand pulling. So the ratio of pull to push, I'd like to say 1.5 of pulling to 1 of pushing the burr. That way you keep your wire and guiding stable. You deliver the burr maybe about 2 centimeters from the lesion. Here I'm dealing with a long lesion, so I want to make sure I really take it slow, because this is the type of lesion which you can run into entrapment. If it goes too quickly, then you get entrapped. So I'm going to demonstrate the technique. I'm here at the guiding, 2 centimeters to avoid the jump. And then you put everything straight, release.
Release the tension.
So I pull back a little bit. You see the burr didn't move. That means I had a little bit of tension in my system. And so ready to go. Make sure that you have someone watching the monitor, because you can't see everything. This is a wire, burr, lesion, patient. You have to have someone helping you, giving you quotes and tips. So we have a pacemaker. We're not worried, but I still want to know, because if I get bradycardia, that means I've had higher chances of having no reflow.
Right.
So let's go.
First
I'll
round.
start with a pecking motion, and then you listen. So I'm having resistance at the mid segment. So you can see here, patient becomes dependent on the pacemaker. So I think we made a very good choice. It was a good call from the beginning, because we had bradycardia, heart rate was between 50 to 60, and you hear the sound of resistance of the lesion.
Right.
I think it was a good choice.
And we're looking to avoid some too important decelerations here. We can hear it when it goes more higher pitched. We can look at the RPMs. If it drops too much, more than 5,000 RPM, we want to make sure there's no burst stall or more decelerations than that.
Yeah.
So now that, yep.
I was going to say that I rarely use pacemakers, but in this case I did. When I do not use a pacemaker, I limit myself to 10 seconds. So I have my assistant telling me once it's 10 seconds, I just stop. You were going to say it, Guillaume? We'll do another run.
Doing fine.
There's a lot of resistance. I don't know if you can hear it. Oh, there you go. Let's save that. There was a jump.
Yeah.
You saw the jump?
Yeah, there was a jump, and the high pitch dropped suddenly. So that means that you crossed the lesion.
How much decelerations did we have? So
down to 170. Down to
165.
Yep. Very nice picking motion. We don't want to go too fast, too slow.
There's still a lot of resistance there. I can hear it.
Yeah, we can hear it. I don't know if you guys can hear it, but there's definitely working on something. There's something going on here.
Let's take a small test, see what's going on.
Yeah, ready.
Go ahead. Okay. In progress, work in progress. Let's go some more. So I think we're good with this burr. Yeah. I don't know if you agree. You want to take a feel for it, see if it's smooth enough to your liking.
Then we can escalate to 175.
We'll do one final polishing. That's very smooth. Okay, so I'm happy to go to 175. It depends on the lesion. If you have one subtotal lesion, I think just crossing would be good. But I think in this case, it's diffusely calcified. I prefer to be sure that we get good expansion, especially that we know that there's probably deep calcium here that we'll see on imaging very soon. All right?
Yeah.
So let's take things out. Guillaume, you want to open the two-way, please? So with the RotoPro, you just put it on Dynaglide, and you have the blue button here to activate, and you take off the brakes. Here we go with the fluoro. So I push back my wire. I barely move. And with the Dynaglide, the burr comes back on its own. You can see I'm not walking all the way to the end of the room. Can you put your finger below? Yeah, very good. It's coming out smoothly. And once you see it coming out, you can just remove your hands and it's stopped. There you go.
Here it is.
Very good. So we'll take the 175 burr, please.
Funnel burr.
And then we'll be able to demonstrate to you how we change the burr, just like the old technique when we didn't have the RotaPro. So you need to stop the drip so we don't get everything wet. I'm going to stop the drip. Then make sure you bring the advancer
All the way forward.
Forward so you don't kink anything.
We can't see.
You take off the yellow sleeve and you pull. Can you zoom in my hands, please? So first thing you do with the 175, you take off this plastic cover. And then the blue one. So then you hold it just in front of the yellow sleeve. And there's like two teeth that need to be facing counter each other. You slip it on, and then you slip on the yellow sleeve, and then you pull, make sure it's well attached. It's fine. Then you hold the plastic end, unlock it, and then you advance everything. So you don't kink anything in. Then make sure you get a click. Now you put on your flush. And once you get the drip, you make sure the burr advances. There you go, drip is on. So then you test it, it's advancing very well. That means there's no kink in the system. Then you lock it like before at the second marker. Turn off the Dynaglide and let's put it on. So again, I'm feeding the burr looking downwards, so I get my drip on the wire. Remove all dye, if there's any dye sticking to it. Very well. Oh, let's test that.
So we're going to test again, Alice. Let's go.
180.
Very
That's
good.
Perfect.
Okay.
Okay, so we'll do the, again, I'll show you a second time, the one-man technique. You insert the burr, make sure you have flow on everything. And then here you go. Watching both sides. So it might be a bit confusing at the beginning because you're operating both hands at the same time, but once you get a hang of it, you don't go back.
Makes things much easier.
So of course here we're in 7 French, makes things much smoother, more support, and at the same time, can I see a bit more guiding, please, to see my burr coming in? There you go. So I'm going to deliver proximally. It's a big burr. There you go. Release the tension. See, the burr didn't move back. When I pulled back my advancer, that means I had some tension in the system.
Yep.
And we'll go very gentle because I know I had resistance in that mid segment and I don't want to have any burr stall. Let's do a small test before we go.
Yeah, ready?
Yeah,
Yep.
Test. Okay, flow is okay. Let's store this. I think I'm going to prepare some verapamil IC, please. And here we go. There's some resistance in that mid lesion, and we're on the pacemaker now. So I'm performing my pecking motion. I'm gonna stop, let it breathe, so we don't get no reflow. I must say the patient is rock stable, which helps a lot when you're dealing with the resistant lesions like this.
Yeah, thanks to the pacemaker. Do you sometimes not use a pacemaker and give verapamil prophylactically?
I rarely give it prophylactically pre-hand but some people do, and it works well
Yeah.
for them. Some people also give theophylline instead. So the burr, if you can notice, it's advancing slowly in the lesion. The sound is better. We don't have any decelerations, maybe 5,000 at some point.
We still hear a bit of
We can still
resistance.
hear the resistance.
168 minimum.
So it was definitely a good call doing a atherectomy here and putting a pacemaker in.
Yeah, yeah.
Sometimes you hesitate. But you know the famous saying of rota regret? I try to avoid that as much as I can.
Yeah, usually when you hesitate, it always means that you should do it.
And the more you do it, the more you become familiar with it, and it just doesn't take longer than bringing up multiple balloons and multiple predilatations.
Very nice.
See, there was something there at the curve and it jumped a little bit.
Yeah, very nice.
But we're okay now. Very smooth. You need to make sure you cover the whole lesion, because if you do just proximal and you miss a little bit distally, you might run into trouble with balloons afterwards. So we'll do one final polish run.
Very smooth.
There you go.
Very
We're all
smooth.
good.
The sound is stable.
Now it's fine.
Yeah.
So let's get out of here.
Down a glide.
Throw. Let's prepare the microcatheter.
Open the turnpike.
We have some ST elevations I can see. This could be potentially some no reflow. So we'll take out the burr and we'll give some verapamil. We'll check the pressure. And we'll swap our rota wire for a workhorse.
Okay, there we go.
All right. Est-ce que vous avez mal, madame? Okay. On va donner Fontanet 50, s'il vous plaît.
Yeah, I mean.
Bougez pas la main, madame.
So there's a little bit of chest pain here. So we're going to give fentanyl here.
We have some rapid AFib also.
Yeah.
We'll give some IC verapamil.
Then have a look.
5. Can you push it?
Okay.
Excuse-moi, Lucie. Let's do a test and see what's going on. Yeah, so definitely no reflow. We'll give some more verapamil. Take care of the no reflow. Okay, let's swap the long wire. Take the rotablator. And
Yeah. You can afford to give a lot of verapamil here because of the pacemaker, so that's a good thing. Again.
see already the STs are better.
Yep.
Let's give some nitro also. So there's questions about, for sure, giving nitro in no reflow. But I mainly give it here because we might have an element of spasm distally because of the burr. Okay, push it. Push, 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 push. No, push the wire, push the microcatheter, please.
Turnpike, yep.
Yep, fixed point. Thank you. Do we have the run through?
Yes. Ready.
Okay, you can take away the microcatheter, the wire.
Moving the wire, going to put back the workhorse.
We'll give some nitro for the distal spasm a little bit. One of nitro. Let's push that.
There you go.
Can we prepare the IVUS, please? STs are much better now. You can see the monitor.
C'est une gonflette pour l'enlever.
Yeah, gonflette.
On va prendre une gonflette.
So this is a short wire. This is a 135 microcatheter. This is my preferred technique, the hydroglide the microcatheter. Let's take out the air. Okay, good. So you need to make sure you don't pinch the wire. Put it on and you go to high atmospheres.
Open the TUI. All right, on. High atmospheres, high
14,
atmospheres.
then you grab the
The
wire.
microcatheter comes out by itself. There you go.
Check position, no change. Okay, good. Let's do a small test. See what's going on. Okay.
Okay, the flow is not perfect, but it's not bad. It's a Timmy 2. So it's
Let's give some more Rapamil, please. But clearly there's a large plaque burden here that explains.
Thanks. Yeah, no, absolutely. So there's still some calcium there. So there may be some deeper calcium than we thought. So we'll have a look here.
I estimate the distal size to be 3.5. I don't know what you think.
Yeah, I think so.
But we'll confirm that with imaging.
I think so.
But I'll prepare already a 3.0 long non-compliant balloon, please. 5 of Rapamil, 10. Push some dye. Maybe we can take a cine. Push some dye. Okay, good. Let's take a cine.
Very nice.
Well, it flows better.
Yeah, the flow is recovered.
So let's see what we have on imaging. I'd be curious to see if we what the calcium looks like. I would have loved to do this before, but I don't think we could have crossed an IVUS.
No, it wouldn't have went through the lesion.
Did you flush?
Yeah.
Okay.
Wait.
Okay, perfect.
Right, so
put it on manual. Click the manual. Hey, can you just bring it close by? Just bring it close by.
No.
Okay, let's go with the IVUS. We do for an ACT?
no, the ACT is 276.
Okay, perfect. Okay, come closer, come closer. Okay, there you go. IVUS is through. All right.
Okay.
So let's get some images.
Can you show the IVUS to the crowd?
Auto, go on 1 millimeter image and put it straight, and we'll pull back.
Here we go.
Large vessel.
Very nice. Okay, so it's free of disease here. Going to measure the distal size afterwards.
I think this would be our landing zone. Let's look. We started with a calcium arc. There you go.
There we go.
That's a 360 calcium arc. 360. There are zones of fracture. If you see at 11 and 5 o'clock.
So the downside of IVUS here is that when there's a 360 calcium arc, it's impossible or very difficult to see if there's some deep calcium there as well.
Well, you can still see some shadowing behind that arc.
You can see some shadowing, yeah. Having used OCT, we could have seen deep
Really?
calcium a little bit better. But, you know.
Would it have been your choice here to use OCT? Would have used OCT more?
Yeah. For the better resolution. But, you know, this was very useful because we could measure the distal segment and then we see that there's still calcification.
We have good images, proximal and distally.
Right.
We have very good landing zones. All right.
Okay.
So let's stop this and let's analyze.
Okay.
So let's get a measurement on the very distal segment just before the lesion.
Distal, Mathieu, distal au début. Ouais, ici, juste avant la lésion. Avance
A
encore.
bit more. Go further down.
Avance.
More. There you go. Yeah, stop. Let's measure that. Let's get diameters on that or use auto measurement. Yeah, diameter. It's very, very strange. The vessel looks pretty healthy otherwise, proximally and distally. And then you have that mid segment that's very severe. So we said 3.5. IBIS tells us 3.7.
Yeah,
so.
and we used a 1.75 burr, so that was a good choice. It's about half of the final diameter.
Yeah.
Okay.
Can we have the 3.0 balloon? 3.0, 25 or 20 balloon non-compliant, please? So we want to make sure that we have good expansion on the balloon before putting in any stents. That way we have an optimal result. And I think this is key here, using imaging when dealing with extensive calcification and you start doing plaque modification and advanced techniques.
No, exactly. And if the balloon opens properly, that means that the stent is going to open properly. If not, then we can debate whether or not using another size of burr or going with IVL directly.
Yeah, for sure. Combination therapy here would be a choice if we have issues. 15, please.
Mathieu, can you measure the proximal diameter as well, please? So we have 3.7 distally, and here, yeah.
A bit more. Move it upward. No, the other way.
Go back to the lesion. Go back to the lesion.
Yeah.
Okay,
come back.
Here.
Stop there. Measure diameter here, please. So this is our landing zone.
4.3.
Wow.
Yeah, I think that was a bit too proximal though. Can you go back to the lesion a bit more? No, I think we're good. Okay, that was good. So can you now measure the length between the two reference diameters we have? So the distance between the 2 points we measured. Tu peux mesurer la distance entre les 2 points qu'on a mesurés?
Test. Okay, go. Let's go to 20 atmospheres.
So we're inflating the balloon here.
So we have a 3.0 by 15 balloon.
Yeah.
So the length of the lesion is 54 centimeters, 54 millimeters. Proximal reference diameter is 4.3. Distal reference diameter is 3.7.
Go.
20.
So we'll end up requiring 2 stents, at least 2 stents.
Off.
So we could use a smaller stent, a smaller 3.5 stent for the distal portion of the lesion, and then.
Well, we can check if we have the Synergy 48, because that would be a perfect choice here, since we know that we need to cover very long.
Yeah.
Go.
Can you have a look if we have the 48 millimeter Synergy?
Ruptured. Stop.
If you have it, just bring the box, please.
So we ruptured the balloon. It's an uncompliant at 20 atmospheres. Well, when it ruptures, you just need to make sure you don't have a hydro perforation. There's still some slow flow. That's probably all the plaque burden. Can we have another 3.0 by 15 balloon, please? Non-compliant. Can I have some more Rapamil, please? So it's crazy the amount of no reflow we're getting.
Yep.
It really shows you that.
It was a very high burden of.
Had you tackled this lesion without atherectomy, I think bad results are assured.
48.
Synergie.
Synergie 48. 3.5.
Merci.
Well, go back where to it ruptured. It was at the beginning, the proximal lesion. Okay, go to 18.
18.
Okay, off. Good expansion on the balloon. Go to 18.
So we have a quite good expansion of the balloons.
Yep. Off. And check fluoro. Okay, one last one over here. Okay, go. So do we have the synergy?
Yeah, we have a 48 by
4-0.
48.
There's no 3-5. 3-5.
Down.
Off. Should we do a run of IVUS? Post ballooning?
Yeah, I
What do you
think we
think?
should. I think we should.
Let's see if we broke that calcium.
Yeah.
Because I'm not 100% positive about the expansion in the proximal segment. So let's take a look at that. We'll do some IVUS. Can you flush, please, the catheter?
Yeah.
So the good thing here with the long synergy stent, first is that we can afford to use only one stent, 48 millimeters in length. The other thing is that we will have to consider which antitraumatic therapy we're going to give to this patient. She's a high bleeding risk patient. This patient is going to be on anticoagulation on the long term because of her AFib. So we'll likely give her a short timing of DAPT. So she's going to be on DOAC, aspirin, and clopidogrel. It's safe.
Fullback.
It's safe. It's safe according to many trials, just like the August trial, to stop the aspirin after discharge or between 1 week and 1 month after discharge. And we know that the synergy has been studied and has shown to be safe in HBR patients using 1 month of DAPT alone.
Mm-hmm.
We have the Evolute short DAPT study that showed that compared 30 days compared to longer term DAPT strategy compared to a historical cohort using propensity score matching.
Mm-hmm.
And they showed that with the synergy stent, we can use shorter amount of DAPT, shorter length of DAPT. This has not been validated in the cohort of patients on anticoagulant therapy, but still, this data is reassuring.
And how long was the follow-up? Do you remember?
So it's up to a year.
Okay.
Yeah. And yeah.
So definitely at 84, if we can avoid triple therapy.
Yeah.
For sure.
Yeah.
Because we know that adverse outcomes
Yeah.
are assured.
Yeah.
At 84.
So in the main large trials, the Augustus trial, Pioneer, and Trust, and so on, that compare triple therapy versus dual pathway, the aspirin was stopped at a mean of 1 to 7 days after randomization. So most of the time, unless it's a very high patient with a very high risk of ischemic complications, stopping aspirin after a week could be considered to be safe. And the patient could be treated with OAC long-term and P2Y12 inhibitor, usually clopidogrel up to 1 year.
So Guillaume, in this type of patient, ACS, non-STEMI, long stent, would you be recommending 1 week of triple therapy?
Yeah, I think so. You know, patients with ACS, patients with PCI were all included in the Augustus trial. There was no downside of stopping aspirin earlier. There was less bleeding, and there was no more MACE at 1 year. A secondary analysis of Augustus showed that there might be some advantage of using aspirin for the first week in reducing ischemic events. So probably just 1 week would be fine, and then we would stop it.
Okay.
Yeah.
So I think we have a start plan for the patient. We can tell the treating physician, and we can see the evolution. If any bleeding issues, any bleeding complications, then we have some answers. So we did the second run of IVUS. Can we show it, please? Let's look at the beginning. Okay, stop there. Let's take a diameter to be sure that we have the correct measurements. Yep. Yeah, that's okay. So 3.5 is good distally. and just let it run so we can see we have much more significant calcium fracture and more expansion of the lumen post-ballooning than we did just with the rotablator.
Yeah, absolutely.
So you see there's a large fracture up top.
Yeah.
We don't see that arc anymore. Here we have a 180 arc and there's two segments of fracture. We have much more of a lumen post-ballooning. Same thing here. I think we need to cover that segment. There's some mild disease, but we balloon there. I think we need to cover it. There's some arc, and then we see the healthy proximal segment coming in soon. That's a landing zone. Stop it there.
Yeah, so we may not be able to cover all the lesion.
We'll
with
need
this
a
stent.
bit more.
So we can always go back with IVIS and decide which length is required after we put the stent on. So
the Synergy stent is relatively flexible and it delivers very well. As you see here, my guiding did not budge despite being a very long stent. Okay, let's test that. Well, maybe we can come back a little bit. Okay, I think I'll take that second plaque and we'll just put another stent because we're not going to get everything anyway.
Yeah.
Okay, so let's take it on here.
Bring up.
Good. 14 atmospheres.
And the advantages of the Synergy Megatron also is that it has a very higher radial strength than other stents.
So perfect when you're dealing with such
plaque
burden and calcium
or some off. Very nice for osteal lesions that are highly fibrotic as well, because you don't want only the stent to open. You want the stent to open and stay open on the long run. So we don't want it to recoil, and the Megatron stent is a good stent for that. There's no randomized trial to show us this, but conceptually, that's an advantage.
So we'll do a test here, see how much is missing. Well, looks pretty good. Yeah. Show me another test, please. So cover beyond that branch up top.
I think so.
So maybe a 20. What do you think?
Yeah, 20 is
20 is a good length, I think.
Yeah.
Can we have a 4020? 4020, please. That would be in Promus probably.
Then we'll be able to pulse dilate that as much as we want to.
Yeah.
We're definitely making good progress here.
So I think it's very important when you approach such lesions to have a clear plan of how you're going to progress, so you don't get surprises in the way.
Yep.
I think we had a good plan, and it's moving forward. Do we have an ACT? 4020.
I'll need an ACT syringe, please.
Well, we did it, but I think the measurement's not back yet.
Not back. C'est en cours.
En cours.
Well, we still need the ACT syringes for later on.
Yeah.
So what do you think, Guillaume? Is it safe to pull a pacemaker at this point? So decrease the risk of having perforations? I'm not a big fan of pacemakers, but I don't think I've seen some pace rhythms going in, but it goes with the fact that she was a bit bratty.
Yep.
So maybe we can bring back the pacemaker to the IVC. Usually when I use stiff pacemakers in rotablator, I like to monitor the patient post just to make sure, because I've had a few surprises in the past, and it's never good after anticoagulation and heparin,
right?
To have to drain a tamponade. It's never fun.
No, you're right.
ACT 296.
Okay, perfect.
296 ACT, so we're good.
Okay, 22, c'est bon?
So we have a 4022 stent.
We'll do some overlapping and we should be okay.
That's a Resolute stent here.
Yeah.
Right. Okay, and what do you think for pulse dilating in the distal portion?
Yeah, I think definitely we're going to do a final IVUS run and
decide afterwards.
Yeah.
Yeah.
Yeah, we took that 3.5 to 14 atmospheres, which should take us to maybe 3.6. Definitely a final IVUS run would be very, very informative. Okay, we have a good overlap. Can you attest, please? Make sure we're covering everything. I think this is fine.
Yep.
Okay, go ahead.
So we pull the guiding catheter a bit.
Yeah, go ahead. On 14.
Second stents on.
Ça va, madame? Oui, ça achève. Okay, off. Test. Okay, looks beautiful.
Good.
So let's just give a little love to the overlap.
Yep.
Go ahead. 14.
14.
Wow, look at that.
Super nice.
Expansion,
Super
amazing.
nice.
Off.
Yep.
I think we'll do one more IVUS run.
On s'est préparé pour le IVUS. Ouais.
Okay, let's approach the machine. Can you put it in manual and advance it?
Yeah.
Hold on. Okay.
All right. No,
Okay, can you show the IVUS on the screen?
Can you show the live IVUS, please?
Perfect. Okay.
There you go. We're not in the stent yet. Let's enable the pullback.
We're looking for three things. Is there any edge dissection? Is there good expansion? Is there good apposition? Looks to be well opposed so far, well expanded as well. Maybe a little bit of work there to do for the expansion here as well.
Yeah, I think maybe some optimization.
Yep.
I agree with you on that. Well, there for sure needs some expansion.
Yep.
I think that's where the CTO body was, where exactly at the mid segment. Okay, let's get a oral non-compliant long balloon, please. Okay, proximally. Proximal looks good. It's really that body of severe lesion that's suboptimally expanded. There you go.
No edge dissection.
No edge
here.
dissection.
Looks very good.
Perfect.
Okay. So a little bit of work to do. CAD 0. CAD 0.
Ouais. D'échange. Conflaté là.
Okay.
Done.
14.
The first inflation of the non-compliant balloon at 4.0. We're at 12 atmospheres.
Okay, off.
So we're going to go to the whole length of the stand.
Go ahead. 14.
We're going to use a little bit higher
16.
inflation pressures as we go up.
Off.
As we go more proximally in the stance.
Okay, here's the part where we had malposition.
Yeah.
Okay, let's go. Let's go to 20 here.
Let's see if the balloon expands well.
Let's disconnect.
$18. Okay, off.
Yeah, it's good.
Do a small test. Make sure we have no issues. Okay, there are no issues.
Very nice.
Okay, so let's take an image in epicranial. I'll give some nitro, one of nitro, push that through. Epicranial, please.
Up even. Looks beautiful. There's no waste anywhere.
I think it looks perfect.
Yeah, the flow is good.
Yep.
Okay, let's pull the wire. Very nice.
Very nice. So definitely better than it was at the beginning.
Okay, let's go to LAO 30.
On gauche. Good. Good job.
That's a pretty good result.
Yep.
Congratulations.
Congratulations. So a couple of learning points here. Preparing the lesion, sometimes it's not doable to image the lesion when it's too tight because of calcification. So always have the option of doing rotablation and preparing the lesions before doing the imaging. Although if the lesion is not tight enough, it's always advisable to do the preparation, to do the imaging before, to prepare the lesion appropriately. Second point, rotablator is good for superficial calcifications.
Yep.
Orbital is good for both superficial and deep calcifications, and IVL is good for mostly for deep calcifications.
So Guillaume, in retrospect,
Yep.
do you think you could have used orbital here?
I think so. I think it could have been a good option to start with. And the other thing I like orbital is that the risk of burst hull is very, very, very low.
True.
Much lower than for rotablation. We can go forward and backward sanding of the lesions, which is very useful.
Yeah. And you don't need to change the
don't
crown,
need to change
right?
the burr. You don't need to change the crown. It's a quite big size artery, so I would have debated whether or not using the high speed here.
Really?
So I would have maybe.
For sure. We measured at 3.7.
So
what's your cutoff for high speed?
I don't have a personal cutoff. It just how it feels. At the beginning, obviously I would have used low speed just to try and prepare the lesion first. And if there was a good result and the proximal distal diameter was a 4 or more, I would have used high speed on the proximal part of the lesion. Yeah.
I personally have very good experiences with large vessel, deep calcium, and orbital atherectomy at high speed.
Yeah.
You really get that deep calcium, and there's some, the circumflexes are notorious for that.
Right.
And I got good expansion using orbital high speed.
Yeah.
For me, the choice here of rotational atherectomy was mainly based on the fact that there was I wouldn't say subtotal, but it was severe lesion on a long segment, about maybe 15, 20 millimeters.
Right.
And I've had previous experiences where the orbital atherectomy wouldn't go through. I've shown such cases to colleagues that have more experience in the US, and they told me they tend to predilate with a small balloon before, but then I think...
Which can have some downsides, right? Because
for
if
sure.
you predilate and then
you can dissect and then you're
do
stuck.
dissection, then you don't know what to do afterwards.
Yeah, definitely. But we're just doing a per close of the vein here.
Yeah, it's definitely not advisable to do a rotablation after we created dissection. Although it has been done. It has been done.
You risk of worsening it though.
Right.
Correct? And then
right. So some people
the whole case is jeopardized.
And the last bailout option, it shouldn't be the first option, but the last bailout option, if you do rota and then we put a stent in and there's still some deep calcium and the stent doesn't expand well, we can always do IVL inside the stent.
You know, it could have been an option here had we had the poor expansion on that proximal segment. But, you know, when the balloon ruptured, the 3O balloon ruptured, it could have been an argument for the possible calcific nodule.
Right.
And calcific nodules are notorious for perforation.
Right.
And it's in that case that if you've used rotational atherectomy and you didn't get deep enough in the calcific nodule, then using IVL would be very useful.
Yep.
And all this to say is that, you know, using imaging here really helped us guide the therapy and tailor it. When we saw those fractures post-rotablator, we knew that we could balloon at that point. And maybe a final point on the antiplatelets.
Yeah, so again, antiplatelets, you know, triple therapy is something from the past. We don't use triple therapy anymore. When I say triple therapy, it's aspirin, OAC, and a P2Y12 inhibitors. We know it increases bleeding. We know it doesn't necessarily reduce the risk of ischemic events. So the guidelines and the evidence tell us to use dual pathway therapy, which is of OAC and a P2Y12 inhibitor. The P2Y12 inhibitor that should be used with OAC is usually clopidogrel because one, we have more experience with that, and two, there's a lower bleeding risk. Some patients in the triple therapy versus dual pathway therapy trials were treated with ticagrelor with OAC, but it is not the norm. Very, very few patients were treated with prasugrel and OAC, so we don't have much experience.
There's a signal of higher bleeding?
Well, the number of patients were way too small to say anything.
And probably these elderly patients were excluded.
Yeah, exactly. So you know, the way to go forward is clopidogrel with OAC whenever needed. And we can stop aspirin as soon as discharge. If we are more if we want to be on the safer side, well, we can continue aspirin for a week and up to a month if there was a high ischemic.
You know, I think I would argue here maybe that we have a very large stent, which is a 4O.
Yeah.
So the value of aspirin versus the risk of aspirin plus dual therapy, I think it's high. Maybe it's high that we have higher bleeding risk here.
Yeah, well, you know, and the important thing is to have a shared decision making with the patient, right? We say that all the time. What does the patient value? Do they value more bleeding or more ischemic risk? So this is a discussion we're going to have with the patient afterwards before discharge.
Excellent.
Yep.
So I think we're going to wrap this up. We really want to thank you for joining us here at the Montreal Heart. Myself, Mohamed Nosser, and Guillaume and Jimina. We really had a great time demonstrating this interesting case with very interesting points and learning points. I hope it was educational. Thank you very much for joining us.
We want to thank all the team. There was Mathieu, the radiology tech. There was Valérie on the table, the nurse with us. There was Alice, the other nurse with us in the room.
And Lucy.
And Lucy as well. And hopefully I didn't forget anyone. Annabelle as well. So thank you, everyone.
Thank you very much.